I'm gonna ask you, you could just take a rest and sit down. I'll ask John Whyte to come up also, because maybe we can cover questions or comments for both of these presentations, which have a thematic link to it, and ask you to put on the microphone when you're talking, but invite others to come on up to ask questions or make comments at this time. While you are, I'll point out, last night I was at a presentation by Dr. Robert Temple, immediate head of at the FDA of the Center for Drug Evaluation and Research, and he pointed out that prior to 1970, when Congress mandated adequate and well-controlled trials for medications, that we really had no clue from an evidence point of view about what we consider to be standard medications. So it's only been 42 years since we've really had some experience in sorting this out with things that we know are active ingredients. So maybe that might help a little bit as a perspective. Please, if you can identify yourself and ask a question or comment.
My name is Joe Bleiberg. I'm the Chief of Research at NICO, National Intrepid Center of Excellence in Brain Injury and Psychological Health. I've been sitting watching the back of Jim Malick's head last morning and thinking deja vu all over again, all over again, all over again. I think it was 1978 that we first, or 79, that these discussions first started. And they're not that different in overall outline and configuration from back then. Now, I would wonder, changing the frame, and just give me a little bit of leeway here. If you took the black box that you call cognitive rehabilitation and replaced that and labeled it college education. Now, both have the ultimate goal of increasing skills, changing behaviors for the better, and so on. Now, in terms of college education as a society, we do not look with the granularity. We don't know why is Yale better than Harvard, why or which course within the 128 credits that you took were responsible for your skill at this outcome. Now, I have 4 kids in college, and when I write a $45,000 American University tuition check, I am not knowing which of those classes is going to produce which particular benefit for my child. I am on the assumption, though, saying that 4 years of this is good for her and she will be different when it is over, and better. And that's not always true, of course. The level of discourse here, if we and people are willing to pay out of pocket for these activities and understand them to be good, do we actually, I understand the granularity is important. I understand that departments of education at universities that look at good pedagogy and good methods are important as well. But do we sometimes miss the point that it is the aggregate that should be looked at, while trying to understand, of course, the particular?
So, Joe, I think that's a very interesting analogy, but let me unpack it in a few different ways. So, first, there's an important difference that although people get older during college, they are not recovering from an injury that's often accompanied by rapid natural recovery. So, I think sort of just looking at before and after, depending on who our populations are and when we're treating them, is thornier. Secondly, I would say, if you've been reading the paper as I have, that more people are asking questions about, is Yale worth more money, and that it's not a very different scenario, i.e. there's the case mix question. Students did not randomly get assigned to Yale and their local community college, and therefore their differences in later life achievement are confounded between the input characteristics of the patients and the treatments delivered, just as we have that issue here. But I think the third thing that you raised, which is a very good question, is how tight does the evidence have to be for us to think that something is worth doing? And we clearly have very heterogeneous standards across domains. So, and you know, my favorite is when an insurer who is denying payment for a service then has a family member who needs the service, and they have a really different take on the level of evidence required to want that service when it becomes more personal. So, I mean, that's a big question, and I think from a policy perspective, indeed, the military and every other payment system will have to decide, are we waiting till there's 12 RCTs on 1,000 patients each, and then we'll pay for it, or what?
Yes, and two responses. The first is to the natural recovery and the added complexity of that. Added complexity. If you cannot explain how a college education does benefit, if you add complexity to the question, how are you going? It's going to be harder to even harder to explain. So, that's one thing. I forgot the second.
Can I just say?
That we can use for you, but we're not sure if it's going to work.
Well, let me just, but just one other thing. I think that, you know, a question that you kind of asked is, or that a lot of people ask is CRT effective, or even is this chunk of CRT effective? But what practitioners also want to know is, among the many things I could be doing during this hour, which ones should I do? I.e.,
Yes.
you don't have to say, forget about it, we won't do CRT.
And
you
I
still
don't-
want to say,
yes.
do you want to be practicing the functional tasks? Do you want to be working on cognitive modules in the brain? Do you want, you know, what are the approaches? And to answer those questions, we have to have them well enough defined that we can compare A to B.
Without any negative aspirations to what is going on, it's essential research. I'm just trying to make the point that the answer, in some ways, is asked and answered at one level, and can be asked and answered at a much more deep level and improved upon. But why are we still trying to apply a standard that we apply to no area of acceleration or deceleration of behavior in humankind?
Thanks. Let's try to get in some more questions. We just have a few more minutes, but go ahead, please. Introduce yourself.
Yeah, actually, I'm Jim Malik. I wanted to actually kind of get at something I think that Joe was getting at in a little different way. And I also want to say I think a couple of things have changed since 1978. There's less hair on the back of my head. And also, perhaps more importantly, you know, I think at this point we do have a much better definition of the methodology that we can use. And I really appreciated both of your presentations in defining that methodology more clearly. You know, my question has to do, and John, I appreciated your comments about health services research at the end of your talk. My question is, and it's a bit rhetorical, but, you know, can we not proceed kind of from the bottom up, you know, in the traditional sequence, as well as from the top down? So in other words, could we not think about studies in which we're looking at active ingredients and mechanisms of actions and proceeding through randomized control trials on up to effectiveness, at the same time, you know, that we're trying to address some of these more immediate issues of cost of care and, you know, what's the black box that works to some degree and is worth some investment, you know, through data mining and more broad implementation of an, you know, for instance, you could imagine taking the cognitive rehabilitation manual and doing training throughout the VA system and then seeing whether it makes any difference in any way, you know, at the other end. So.
I think data mining, is very limited in this area. Because if you want to investigate which approach is better than whom, well, they all get paid for under the same procedure code. Yeah, so that doesn't tell you anything. Yeah.
And actually, maybe a prospective, practice-based evidence approach would be more realistic. But you understand my point,
That's certainly a possibility, but as I hoped I made clear, is that when we asked therapists to distinguish the 10 or 20 different categories of treatments, they reverted back to, almost all the time to the easy, well, you have gait therapy, you have swallowing therapy, etc., which, doesn't necessarily tell us very much. And why did it happen? Well, we essentially, weren't smart enough, and John and I didn't start talking yet until these studies were in the field, or else, we presumably had been more aware, whether we had been willing to have a 3-year fight with therapists trying to convince them that they have to describe their treatments different ways, another story. But we need different types of research, no doubt about it, and health services research can be a big part of it, but if we want to use it to tell us which specific flavors of CRT are the best for what outcomes in what population, we need to start out with a better description of the flavors to begin with.
And if I could just make one quick addition, I do agree with you and with Marcel that a wide range of designs should be open for discussion. They need to be as rigorous as they can be. But let's just take your example of the CRT Manual. So that's a very interesting possibility. But I think it would be very dangerous to train everyone on the manual, gather outcome measures, and if they don't change, we'll decide all of cognitive rehabilitation is ineffective. Maybe your training is bad. Maybe your manual doesn't give enough detail. So we need then some sort of adherence measures to say, when people have been through that manual and that training, do they do the things that that manual says? And then we're back to, how would I recognize the ingredients that that manual is specifying if I saw them? And so I think whether you use a more observational data mining approach or an RCT, you can't completely get away from some definition of ingredients that you can look at and measure and count.
Point taken, and I mean, in implementation and research, I think Russ Glasgow's really pointed out the very many points at which it can fall apart, but just want to put it on the table.
Let's try to get in 1 or 2 more questions or comments briefly, if you can introduce yourself. Thanks.
I'm very short. Allison Cernich, VA and DECO. One comment, and just an analog from the VA perspective, give everybody a manual and send them out and do the treatment, and we'll just figure it out from there. The analog to that is in mental health, for example. Right? So there's a fairly large body of evidence on manualized therapy for psychological conditions, for PTSD, for insomnia, for depression. Look at the research and look at the compliance rates. So as much as you try to operationalize these interpersonal treatments, these things that are delivered from person to person, taking that personalized medicine approach, the risk that you take, and I'm not arguing against the empirical evidence because I think we need it. I'm not in any way looking down on that. But I will say that you affect your compliance, okay? Because if you look at the dropout rate when we do those national studies for evidence-based practice for psychological health treatments, the dropout rate is substantial. And it varies. It doesn't, we've tried to look at, is it the severity that does it? Is it the lack of pharmacotherapy that does it? Is it the number of comorbidities? It's very unpredictable, and we're doing this in large swaths of the population. So it's not that it's unachievable. It's not that it's not manualizable. It's not that it's not able to be operationalized. I think cognitive rehabilitation therapy lends itself to that, sometimes even more than prolonged exposure or other CBT treatments. What I'm saying is, though, that you have to take the inherent risk that the more you manualize this type of therapy and the more you take it away from the interpersonal exchange, especially with a population that has other disabilities, that has other functional limitations, that has environmental barriers and other effects of that disability that may not be the same for people with depression or PTSD. My concern is with that I think the research and the theories and the other things that you've suggested are fantastic, but the other thing within the conversation that I think we may want to consider is what's the effect, if you go that route, on your compliance, on your ability to deliver, and then eventually on the outcomes that you eventually gain when you try to make it more generalizable. That's my only.
Real brief, 30-second reply.
My question is it the patients who walk away from regimented therapy, or is it the therapists who are so unhappy having to follow a manual that they drive their patients away? Whatever it may be, yeah, we should be able to come up with some system where there is key elements in treatments that we want to be there, or else we want call it treatment X and pay for treatment X, and leave enough freedom to the therapist so that they can individualize that for a particular patient. And we haven't even developed all the manuals yet, let alone that we have determined what variation on the manual we can permit.
Let's, by the way, I should point out in randomized controlled trials of more traditional interventions that we know the active ingredients, that compliance and dropout rates are still a big bugaboo in terms of interpretation on them. Do you use the last observation carry forward, and a whole bunch of other issues. So I think it's a really good point, but it's not just specific as an issue here. One last question and comment, and please, go ahead, sir.
Hi, I'm Paul Hammer. I'm from DECO as well. I looked, as I was watching the slides and trying to understand the presentations, maybe pharmacology is not the best analogy that we can use, and the thought occurred to me was exercise physiology. You know, it's like prescribing exercise. Well, what do you mean? Run on a treadmill, go for a walk, lift weights, do some stretching, do yoga. I mean, there's numerous other things. So it might be, and there's a good body of literature on, you know, lifting weights 3 times a week, and, you know, and you have a wide variation between Olympic athletes and your run-of-the-mill guy who is just goes for a walk every evening and lowers his blood pressure because he lost 10 pounds. You use the patient as their own control group, and in a sense, and there's a number of ways that you could use that analogy to do the research better, I think, than what we do with pharmacology. And I thought I'd invite your comments on that as a concept. It may already be out there.
Well, I mean, we include the whole range of things, including exercise, in the type of taxonomy we're trying to define and structure. You know, as the issue of can you use a patient as their own control is wound up with this issue of where are they in the chronicity curve, how subjective is the outcome if you think you should be better and you say you are versus it's an objective and measurable thing. So, but yes, I think exercise is one of the many kinds of things we deal with, and where you can ask, I mean, the exercise that is good for strength training differs some from the exercise that is good for endurance training. So there is some, it's not just like exercise is good, don't need to define it. It's as we start sharpening what it is we want to achieve with it, we also end up sharpening the ingredients that are likely to be most useful for achieving that.
Thank you very much. We're going to have to stop the questions and discussion. I know John's got a few minutes to kind of set the stage for this afternoon. So while you're getting prepared to do that, John, I just want to take this opportunity also to recognize and thank the members of the committee who are involved in the planning, Charles Drebbing and Rich Keefe, who are not here right now, but particularly to Drs. Mary Kennedy and Hillary Thompson and John Whyte, who really worked hard in terms of planning this. Many thanks to you. We'll hear more from Mary and Hillary in their involvement later this afternoon. I also want to especially also thank the staff who we've worked with going on about 2 years now, particularly Rebecca Kohler, who was the staff director for this, and her boss, Dr. Rick Erdman, and also to Mary Jo Oster and John Sanders. In fact, John will, just as we break here, will give us directions about where to go to lunch and how to do it and how to get back. So we'll turn things over to you, John, and as tidy as you could be. Thank you.
Okay. So this afternoon and tomorrow morning, we're going to be going through 3 small group exercises focused on 3 different treatments that we picked from the set that were reviewed for the study. We picked treatments that we rated as 2+, 1+, and 0 because we want to give you some experience in thinking through, given where a study or given where a treatment is in terms of how we understand it, what would be the useful things to do next. Now, as I said, these treatments won't have all moved methodically through that pipeline, so you may have to, back something up a little bit or be a little idiosyncratic about it. But what we're hoping is that you would take these treatments where they are and say, if we were to want to move this forward, what would be the useful research agenda in the near term? Now, just a few disclaimers about that. First of all, we would like not to spend the sessions arguing about that should have gotten a 2+, not a 1+, blah, blah, blah. So none of them are good enough to be, let's go out and sell it. We know for sure it works. Everything can be moved forward. So just think about where you think it is and move it forward. Secondly, we're not advocating that these 3 treatments are the ones that the military should invest in moving forward. These are chosen as educational exercises. And so that has an implication also for the small groups that, well, we're interested, of course, in you thinking about specific outcome measures that might be good or whatever. We're most interested in the generic issues that come up across groups and across the treatments. So see if you can, in your discussion, sort of abstract out the big picture messages, if any, that would apply to other treatments that the military might wish to develop rather than these. If we just figure out these 3 treatments, that's probably not all that useful. We've given you some questions to try to structure the discussion. One of them is what you think the treatment theory is, and I don't think any of the authors will have given you the answer to your or our satisfaction, so you'll have to do what we do, which is make inferences from what they say, from your own knowledge, and so on and so forth. Just a couple of other complexities that we didn't get a chance to talk about in the talks that may arise. So when treatments are, we've talked about the issue of restorative versus compensatory. But just one thing to think about is that we would, in general, say that a compensatory treatment, the treatment object is not the impairment. So if you have a memory impairment and you're going to use a memory notebook, is that going to fix memory? No, it's going to fix tasks that rely on memory, tasks of certain kinds that rely on memory, and very likely not fix tasks of other kinds that also rely on memory but that don't lend themselves to a memory notebook. So think carefully about the object, i.e. the thing that thing can really treat, especially if it's a compensatory issue. Secondly, I think you will find that many of the things in these articles that are kind of laid out as a treatment are, by my and Marcel's definitions, more than one treatment. That doesn't mean they're bad. It's very often good to have a package of ingredients that work coherently together. But just to give you a simple example, virtually every time you have a compensatory device or strategy, you have the selection of the right device. Is this the thing that they need? And then how do they learn to use it and apply it? And the reason we bother to separate that is because different things about the patient and different things about the therapist are going to affect the success of those 2 things. You can pick a really good device and not give adequate training and it won't work. You can pick a bad device and give really good training and it won't work. The factors that determine what's good training and what's a good device are 2 different sets of factors. So you may need to divvy up a thing into pieces in order to have the most coherent conversation. So we're going to start after lunch we thought it would be easiest to start with the most mature. It lends itself a little more quickly to kind of traditional research designs and thinking about how will we really make sure this works. And as you build up your mental calluses through this activity, we're going to challenge you to things that are farther and farther upstream, need more and more work to get them to a more mature state. But hopefully by the end of our session tomorrow and wrap up, we'll have sort of been able to learn some general lessons about forward movement of research of this kind. Did I fail to say anything we need to? Yeah.
John, can I just ask what guidance you might be able to provide them in a situation where they're having an hour to talk about this, lots of questions. Is there a priority? Which is the most important thing we're talking about first, second?
Well, that's a good question, which I haven't thought about. But I think what I would probably suggest, but other people can weigh in on this if you disagree, is try to talk about everything at the level you can talk about it. So, for example, if you say, oh, well, we need an outcome measure about like whether people really successfully go shopping. I don't know if there is an outcome. Well, just say, okay, that's what we need. Let's not do a literature search to find out what shopping outcome measures exist. So I would say try to touch on each of these things, say as much about it as you can in a short time, and then in the discussion, you can say, we couldn't figure out what the hell the treatment object was. Help us understand that. Well, two other groups are talking about it too, and we can solve some of that in the wrap-up discussion. Does that work for people? Okay, so you've all been assigned small groups, and one of the planners will be in each of your small groups. All the small groups are a mixture of people who have a lot of experience in this area and don't. It's not about that. It's about the whole conversation. So, yeah. Yes. Okay, and somebody was going to do logistics about, oh yeah.
Yeah, one of the rooms that's changed on the agenda from the agenda books that we sent out. We're meeting in rooms 227 and 280. They're basically right outside this door. There's an elevator. You go up to the second floor and hang a left, and just follow the corridor, and you'll find both rooms. If you don't want to get lost in the maze of the academies, just come back here, and at 1 o'clock, we'll have staff members in here to guide you up. And the cafeteria, if you go out the door here and hang a left and go through the Great Hall, right past the Great Hall, if you came into that entrance, you'll see a little staircase to your left. Go down that staircase and you'll be right in our refectory. So.
And other than coming back here to pick up the trail of breadcrumbs, we're going straight to the small group rooms from lunch at 1 o'clock.
What exactly is going to be the outcome of these 2 days, sort of concretely? Is it going to be a report that does, what is it going to contain?
So at the end of this, we'll produce a summary of the discussion and all the things that went on in the small group. In addition, we're having it videotaped so that, the dissemination from this can reach a larger audience.
So it's not going to be like a listing of all of the top research gaps that exist and what should be done? I'm asking.
I think we heard in the beginning, which maybe you missed, that ours was not to make recommendations for policy or action. That's what you guys will do with the process after we leave.